You should be able to go in the next few seconds.
Okay, can everyone see my screen?
Yes, thanks.
Okay. All right. So today we're going to be talking about overdose and poisoning. All right. Okay. So just an introduction. So poisoning and overdose is a relatively common occurrence in our socio-economic setting. So poison refers to a substance that is capable of causing harm or death when introduced or absorbed by the body. And overdose refers to the consumption or administration of a drug in excess of the prescribed dose. So both of which can be deliberate or accidental. So we can group poisoning and overdoses into toxidromes, which is usually defined by the mental state, vital sign trends, as well as other physical signs. So in this presentation, slide. Okay, so the points that we're going to be covering in this presentation is first we're going to start with the general approach to overdose and poisoning. What would you do if you get a patient like this, and how to approach it, how to have a structured approach, when to suspect poisoning, especially if you don't have a history, the toxidromes, the different types of toxidromes, and this is shown here, the cholinergics, anticholinergics, and so forth. We're also going to go through some paracetamol, overdose, INH poisoning, warfarin poisoning, and then we'll just touch on snake bites as well. Okay, so the general approach to overdose and poisoning is a mnemonic you can use, RRSI dead, that can help you give you, a structured approach when you have a patient like this. So the first R stands for resuscitation, and that's your ABCDE, with also attention to things like hypertension, hypotension, arrhythmias, seizures, hypoglycemia, hyperthermia. Okay, then your next R stands for risk assessment. So this refers to taking into account the agent, the dose, time of ingestion, current clinical status, and individual patient factors, for example, their weight, comorbidities, etc. Okay, so the next is supportive care. So there's also a mnemonic that you can use. It's fast hugs. So this is also quite important in poisoning and overdose, given that most overdoses don't actually have antidote. So you're looking at feeding and fluids, analgesia, sedation, thromboprophylaxis, seating the patient up in a head-up position, ulcer prophylaxis, glycemic control, bowel care, removing any catheters, and appropriate antibiotics and de-escalation thereof. Okay, then the next one is I, which stands for investigations. So ECG especially can be extremely helpful, can identify potentially lethal cardiac conduction abnormalities, and can be really helpful too. Paracetamol levels is another example. However, this might not be available in a primary healthcare setting or be available on time for that matter. Okay, the next is decontamination. So decontamination refers to procedures that aim to reduce absorption of an ingested agent, and it is indicated where expected benefits of the procedure can outweigh the risks. There is, however, potential risks of decontamination, for example, aspiration of charcoal, and you obviously need good supervision of the patient, which may also not be available. Okay, and then enhanced elimination. These are interventions that are aimed to enhance the elimination of an agent. Examples of this would be urine alkalization or hemodialysis. Okay, then the next A is for antidotes. And antidote is a substance that can correct the effects of a poison, but you also need to be aware of any side effects, like any other drug. Okay, then disposition. So again, an initial risk assessment allows for early planning for appropriate disposition, and obviously arrangements need to be made for this. And And the management should be discussed with an accepting institution to allow for mobilization of resources and preparation for urgent interventions as well. Okay, so when to suspect poisoning or overdose. So if you have a patient and you don't really have a history and you have nothing much to go on, these are some of the features that will point you in the direction of a poisoning or an overdose. So another acronym here is toxidromes. So you can, if you have patients with temperature abnormalities, foul odors, extrapyramidal signs, ileus, dry mouth, excessive salivation, delirium, rashes, or if you have a history of overdose, muscle tone abnormalities, eyes or pupils constricted or dilated, ECG changes or seizures. Okay, so toxidromes, as mentioned before, it's a group of vital signs and features found on examination associated with a specific group of toxins or drugs. So this, we're going to go through these common types of toxidromes. We'll just do a quick overview of each one. Okay, so just looking at paracetamol. So the mechanism of paracetamol overdose is acute liver injury that results from accumulation of the toxic metabolite of paracetamol. So increased concentrations of this metabolite depletes glutathione, which is required for conjugation. So the clinical features that a patient with paracetamol overdose may present with. So up to 1 day, they can have nausea, vomiting, sweating, can progress to metabolic acidosis. From 1 to 3 days, they can be asymptomatic, but hepatic toxicity can develop, and therefore they need monitoring of their LFTs. And 5 to 14 days, you can have recovery with resolution of the hepatic enzymes, or death can also occur if the patient was in liver failure. So the toxic dose of paracetamol is more than 200 milligrams per kg or 10 grams, whichever is less. So the management of paracetamol overdose. Decontamination, activated charcoal can be used, but that's if a patient presents to you in time less than 2 hours. The antidote is N-acetylcysteine. So if you do not have paracetamol levels within 8 hours of ingestion, which we usually don't, given our setting and how long it takes for the paracetamol level to be available, so you would start N-acetylcysteine. If it is more than 8 hours of presentation, and you start N-acetylcysteine if a toxic dose was ingested or the patient is showing clinical signs of toxicity. So also to remember that drugs do have side effects. So N-acetylcysteine releases histamine, which can mimic an allergic reaction. If this does happen, you can slow down the infusion and add an antihistamine, or in case of bronchospasm, you might have to stop the infusion. So the dose for N-acetylcysteine is you are given initial infusion of 200 milligrams per kg in 500 moles of dextrose water over 4 hours, and then a second infusion can be started at 100 milligrams per kg in 1 liter of 5% dextrose water over 16 hours. Further management, well, ideally you would want to look at the nomogram and plot the patient given the paracetamol levels, but as I said, it probably will not be available within 8 hours of ingestion. Okay, then the next one is cholinergic toxidrome. So examples of this is your organophosphate poisonings, your pesticides, and this is very, very, very common toxidrome that we see. So absorption can be through the skin, it can be oral or inhaled. So the mechanism of cholinergic toxidrome, so the organophosphates inhibit acetylcholinesterase that allows for the accumulation of acetylcholine. And this occurs at the cholinergic junctions of the nervous system, at the site of muscarinic activity, and at the site of nicotinic activity. So these patients, they present to you confused, and other clinical features, for muscarinic features, dumbbells is a common mnemonic that we use. So they present with diarrhea, urination, meiosis, bradycardia, bronchospasms, emesis, lacrimation, lethargy, salivation. So another B that is reporting is bronchorrhea. And the nicotinic features, hypertension, tachycardia, weakness, fasciculations, paralysis, mydriasis. And then they also present CNS features, anxiety, insomnia, seizures, tremors, confusion. So the management of a organocholinergic toxidrome, so resuscitation, aspiration of bronchospasm may require intubation and ventilation. These patients also need hemodynamic monitoring. Seizure control with benzodiazepines is also indicated. Decontamination of these patients, their clothes all have to be removed and placed in a plastic bag, and healthcare workers need to be keep themselves safe, make sure they have gloves and masks on when they go into these patients. Okay, so the antidote for cholinergic toxidrome is atropine, which is given 2 to 5 milligrams IVI. You then have to reassess the patient every 5 minutes for evidence of atropinization, and the features of this is that you will have decreased secretions, so the bronchuria will be improving, and improvement of the bradycardia as well. If there is no response, then you have to double the dose, and if there is a response, you give the same or a reduced dose. After that, an IV infusion is indicated, and this would be the total dose of the atropine that was given initially, 10 to 20% of this per hour. Okay, Rahul will present the anticholinergic toxidrome.
Hi everyone. So I'll be presenting from now on. So the anticholinergic toxidrome, most common causes of the anticholinergic toxidromes are antihistamines. Antihistamines can be anything from allergics that you take over the counter to tricyclic antidepressants that we prescribe for neuropathic pain, such as amitriptyline, all the cyclodenzaprine, the orphagrine, anti-Parkinson agents. So the mechanism for which this cholinergic anticholinergic toxidrome works is that it blocks the action of acetylcholine at the central and peripheral receptors. The clinical features, I don't know if we remember this as med students, but there's a mnemonic. So not a mnemonic, a saying. So hot as a hair, blind as a bat, referring to the mydriasis, the dilated pupils, dry as a bone, red as a beet, mad as a hatter, full as a flask, referring to urinary retention. Management for the anticholinergic toxidrome, it's obviously the initial supportive management, activated charcoal within 2 hours, diazepam to control seizures or status epilepticus management, ECG, continuous cardiac monitoring, and referral, even if there's no response to treatment or this, I would refer. Next slide.
Sorry, one second, my slide is not moving. Oh, there we go.
Okay, the next slide is the serotonin syndrome. Now, the serotonin syndrome, it's caused by monoamine oxidase inhibitors. Usually, they're the ones responsible for the serotonin syndrome. It's either that alone or in combination with SSRIs. SSRIs alone are not shown to really cause the serotonin syndrome. It's usually the MAOIs in combination with serotonin reuptake inhibitors. So the mechanism is through the activation of the serotonergic receptors by either inhibition of the serotonin uptake or decreased metabolism or increased synthesis of serotonin. The mental state would be confused, agitated, or in a coma. Pupils are dilated, they're usually hypothermic, tachycardic, hypertensive, tachypneic. They might have tremor, myoclonus, hyperreflexia. The management with this is always supportive. supportive fits monitoring. Benzodiazepines have been shown to decrease serotonin levels, as well as the other neurotransmitters. ECGs for cardiac monitoring, and obviously all other monitoring interventions. Okay, then the sympathomimetics. Now these include the cocaines, or amphetamines, the methamphetamines. Most commonly, cocaine is the most common sympathomimetic that we see. Now, the mechanism that these work is the inhibition of the catecholamines, such as norepinephrine and dopamine reuptake. So the effects are related to basically an increase in the in the sympathetic nervous system. Mental state can range from hyper-alert, agitated, hallucinations, paranoia. Pupils are dilated most of the time. However, there are some cases where it can be the actual opposite of it, where you can see an hypertensive patient with a bradycardia. However, the pupils are dilated. So supportive management for these patients would be your ABCs, and also just like go through their clothes. Usually these patients, they carry the drugs with them, which gives a diagnosis away. Diazepam, it's required for these patients, and high doses of diazepam are actually shown to be better than using beta blockers or labetalol infusions, even for the severe hypertension. Fits monitoring and routine monitors also. Next slide.
Slide, my turn.
Um, um,
Can you see my screen?
yes.
If you click on the arrow, go to the bottom left-hand corner, you'll find the arrows that allow you to move. Right at the bottom, on the left bottom corner. Left. There we are.
Okay, so opioids, we all familiar with opioids now. Well, hopefully not. So heroin, morphine, methadone, oxycodone, hydromorphine. Usually opioids are taken in combination with ethanol, which potentiates their mechanism of action, which is the activation of the opioid receptors in the CNS, causing inhibition of the synaptic neurotransmitters, resulting in CNS depression. Their mental state, you'll get a decreased GCS, depressed CNS. They can come in a coma, bradypnea, apnea. They may develop hypothermia, bradycardia, hypertensive. What usually gives the diagnosis away are the pinpoint pupils. Other manifestations are the hyperreflexia, the pulmonary edema, needle marks, the tram tracking. So specific management would be supportive always. The antidote is naloxone 0.4 to 2 milligrams, repeated every 2 to 3 minutes as required, with a maximum dose of 10 milligrams. So obviously we'd give naloxone before intubating a patient, because it would be counterintuitive to give naloxone after a patient's been intubated. And also just remember that naloxone has a shorter half-life and a duration than opioids. Okay, then sedatives, your benzodiazepines, or any alcohols, your sleeping tablets, or anything that basically brings a patient, that increases GABA stimulation or reuptake. So the mental state of the patient, again, just like opioids, will be depressed CNS, confusion, stupor, coma. Vital signs, they might be normal, they might develop it. They range from hypothermia, bradycardia, hypertension, apnea, bradypnea, hyperreflexia. The antidote, which is not available in clinics, however, in Para it is available, is flumazenil. Sorry if I said that wrong. The management, again, it's supportive. They might require ventilation. Okay, next. Then hallucinogens. So hallucinogens, they might be confused with substance abuse, substance-induced psychosis. So, however, the management for these remain the same. Benzodiazepines, if for sedation, mental state, hallucination, perceptual distortions, depersonalizations, similar to substance abuse, substance-induced psychosis. Pupils, they're usually dilated. Vitals, there may be hypothermia, tachycardia, hypertension, tachypnea. Yeah, so specific management, benzodiazepines for sedation, and monitoring for differentiation between a psychotic disorder and organic disorder, such as LSD or ecstasy ingestion also. Salicylates, your aspirin overdoses, and yeah. So the mechanism that how this works is that it inhibits prostaglandin synthesis and prevents formation of platelet aggregating substance. Your thromboxane A2 inhibits both vitamin K dependent and independent clotting factors. Your clinical features, you can get your GI bleeding, your hyperkalemia, tachypnea, vomiting, sweating. It progresses to respiratory alkalosis, seizures, confusion, metabolic acidosis, respiratory and renal failure with higher doses. So management with salicylate overdose is your supportive treatment. Your IV fluids, your ABCs, correct hypokalemia, seizure control, blood products such as FFPs may be required for hemorrhage. Then, so usually they don't present within the time frame for activated charcoal. But if they do, then activated charcoal would be a decontaminated process. Elimination, IV Sodabic for urine alkalization, and dialysis for complicated cases. Ethanol, the mechanism is a CNS depressant, it's a respiratory depressant. Clinical features of ethanol ingestion, your acetone breath, acidosis, CNS depression, hypoglycemia is something that we should always think of. Electrolyte abnormalities, hypertension, seizures, tremors. Management, supportive management. Again, your flumazenil or naloxone to alleviate respiratory depression. IV fluids, thiamine, correct hyperglycemia and other electrolytes, seizure control with benzodiazepine, and always remember the alcohol withdrawal syndrome afterwards. So in our population, many people are taking TB medication for TB. So isoniazid poisoning. So it's the metabolism of isoniazid. It produces a reactive metabolite that binds and damages cellular macromolecules in the liver. There's a triad of seizures, metabolic acidosis, and coma. The antidote is pyridoxine, 1 gram for every gram of isoniazid. Usually we don't know how much has been taken, so we usually just give the maximum dose, which is 5 grams, and then supportive care and benzodiazepines for seizure control. So anticoagulant poisoning. So patients that are on warfarin that accidentally ingest more warfarin than needed, or deliberately take rat poisons, which the new rat poisons have a super warfarin, which is more potent and have a longer duration of effect. So warfarin is a vitamin K antagonist. Bleeding is the main clinical presentation. Management ABCs, your circulation, stop the bleeding. You might require FFPs initially, and then your vitamin K. So patients are usually on on warfarin for some sort of reason. So you have to have a bleeding risk assessment and monitor your INR and correct it accordingly. And just have in mind that superwarfarin may require months of vitamin K therapy. So snake bites. So usually snake bites are underdiagnosed because the snake is not usually identified, and they're not actually available to tell us the history. So there's 3 types of venoms: cytotoxic, neurotoxic, and hemotoxic. Cytotoxics usually puff adders, presenting with pain, swelling, blisters, necrosis, hypertension, and a compartment syndrome. Neurotoxic features, paresthesia, visual disturbances, ptosis, drowsiness, weakness, and respiratory paralysis. And hemotoxic features, which is spontaneous bleeding, headaches, and dizziness. Management at the primary care level would be supportive and symptomatic management, mechanical ventilation if there's a neurotoxic venom, blood products if available. But the mainstay of this thing would be to contact the relevant poisoning or slipping my mind. The poisoning information center. So in conclusion, a structured approach here is needed to adequately manage the patient, as Karishma identified. So stabilize the intoxicated patient, use family and friends for collateral history, a thorough physical examination, including a primary and secondary survey to help identify the toxidrome, quick referral, treat the patient, not the toxidrome, Poison Information Center, the Tigerberg Poison Information Center, the Red Cross War Memorial Children's Hospital Poison Information Center. That's our references. Thank you very much.
Thank you very much. Well done. Can I suggest that you just put out the Tigerberg one? I couldn't find the number, so that everybody has it on record. Thank you very much. And I think well done to you. I think I really like the fact that you put out your references on each page. It was useful for me to reflect on when you were presenting things. Just as a general rule, try to look, and it doesn't apply to this one because I think this might be still applicable even though it's years old. Always try in your presentations to get the latest you can, latest guidelines. So don't look too far back when you do think whether there's something more current that you picked up on. All right. Thank you to Rahul and Karishma. Mankosi, you next. Give me a few seconds. You are able to